Hi, I'm Joelle St-Pierre. I'm a gastroenterologist and clinical assistant professor at the University of Calgary in the IBD unit. As part of my practice, I take care of patients with inflammatory bowel disease. And to do so, I use a tool called intestinal ultrasound to be able to help inform my decisions. So what is intestinal ultrasound? You may have heard it before. It's a bedside tool, an imaging modality using an ultrasound machine that allows us to look at inflammation in the gut. It does so in a non-radiating point of care way that enables us to make decisions that day. How I explain it to patients when I do an intestinal ultrasound is I measure a few parameters that tell us if there's inflammation or not. The way I say it is, it looks like inflammation in your skin, but in your bowel. So then things that we look for are thickening of the bowel wall, similar to edema when you have a burn on your skin. So one of the things that we look for is bowel wall thickness. Less than 3 millimeters is normal in most patients, whereas anything above that makes us suspicious for active EEs. The second parameter that we look for is called hyperemia. That just means increased blood flow. Again, similar to that burn on that skin where you'll see redness from those little blood vessels. Similar to inflammation in the bowel, we have increased blood flow. And through a special technology called Doppler, we can look at that microvascular flow. Together, those two parameters definitely help us detect inflammation. There are other parameters that we look for as well that can help inform our decisions. As part of, to be able to do intestinal ultrasound, we need to be certified. This is done through the International Bowel Ultrasound Group, or IBUS. And in recent years, we've had IBD nurse practitioners be able to go through that certification as well. If that's something you're interested in, you can look at the IBUS website for further details. Now, when do we integrate intestinal ultrasound in our practice? There are a few key places where it really is valuable. First is at diagnosis. Not that it replaces colonoscopy in any way, because we need tissue and biopsies to make that diagnosis. But it can help triage the urgency of that colonoscopy, whether we need to jump on it right now, or could these symptoms be attributed to something else. Second time is if a patient has a diagnosis and we're wondering about an acute flare or an active inflammation in the bowel, then we can bring them in clinic, and that day we can determine whether there's a high inflammatory burden because of this tool. And lastly, in treatment monitoring. So once we start a treatment, we want to know if it's working well. And so what we'll do is we'll have a baseline, start a treatment, and bring the patient back at different time points. Usually around the 3-month mark, we can see really good changes if a patient is responding. And again, through those parameters, we can see whether we're getting improvement or a response in the bowel.